Hello, I'm Deepika from the University IIIT Delhi, India. This study comes out from a deployment work that was conducted in 2019 in India with the collaboration of an NGO SWACH, and our research is supported by Bill and Melinda Gates Foundation. Our study focuses on improving the training and learning opportunities of community health workers in India who are known as ASHAs by investigating alternative mobile-based solutions. We identified the training needs of the health worker through a large-scale deployment of a mobile-based training tool for the training of 500 ASHAs. The tool is low cost and overcomes the constraints of low literacy and lack of access to computer and smartphones by ASHAs by using interactive voice response, such that trainers can conduct audio-based online training sessions. The ASHAs just need to have access to basic phones through which they connect to these audio conference calls, where they listen to audio material, interact with the peers, and interact with the expert by giving touch-tone inputs. In a period of 6 months, 500 ASHAs were trained on the 6th topic of home-based postnatal care in 20 batches, which means one batch had a size of around 20 to 25 ASHAs. Total 144 sessions were conducted. From these sessions, we collected 1178 question and answer exchanges between the expert and the ASHAs, which we analyzed to understand the information seeking of the ASHAs and their gaps in knowledge. We then mapped the ASHAs questions with the reference material they are provided, and finally interviewed 48 ASHAs to understand their rationale of information seeking, their training experiences, and expectations. Our analysis of the questions found 75% of these to show gaps in the basic knowledge to deal with the field cases. We understand this by developing a detailed distribution of the topics and severity of the health problems. We arrived at 3 areas which need attention. First is improving knowledge on routine care and problems for which community typically do not consult expert and rather approach ASHAs as a first point of contact. An important aspect to address these that was highlighted in the queries was related to the cultural associations that contains various kinds of beliefs and practices. And because of the lack of knowledge, ASHAs showed difficulty in using their cultural competence and helping the fellow community members. The other 2 themes were on danger sign and breastfeeding support. On mapping the questions with the reference material, we found the coverage to be low. Only 22% of the questions could be answered, 15% were partially answered, and 16% could not be answered at all. We found basically 3 gaps with respect to the coverage, presentation, and accessibility. First is the material is comprehensive, however, it is inadequate to answer what ASHAs are currently seeking for their community needs. And second, the material is present in form of lessons and chapter forms, whereas from the deployment, we found that ASHAs require content in form of Q&A format, which they can easily use by searching the topic of their queries and field cases. And third requirement that was highlighted by the ASHAs in the interview is the access to material in form of audio-visual material, which they can use in the fields on on-demand basis, for example, while interacting with their clients during the home visits. A key challenge that our deployment faced was related to the poor cellular connectivity. 86% of the participants faced at least one call drop in every session. That means they had to reconnect to the sessions and miss portions of their sessions. Voice quality issue was frequently reported by many of the ASHAs. And ASHAs navigated these challenges by adjusting the locations from where they attended these sessions. Finally, in conclusion, we draw 4 implications from our study. We need to improve the design of reference material in terms of coverage of the common questions ASHAs ask, which also represent the unmet needs of their communities, and enable ASHAs to effectively use these material. Second is mobile learning platforms fit into the context in which ASHAs work and have good scope for providing learning opportunities on continued basis. Third is interactive voice response is powerful in terms of reachability and overcoming the constraint. However, poses barriers in user experience that we face in form of call drops. Finally, in order to improve the knowledge and skills of ASHAs, we need to work on basics and focus on problem solving and counseling skills. Thank you very much. I'm happy to take the questions.